Next presenter is Dr. Sanjay De Bakshi. He will be presenting on the undefined or atypical cystic tumor of the pancreas, pragmatic decision making. Dr. Bakshi, please.
Thank you very much, and thank you delegates for coming to Calcutta. We were very, very worried indeed whether this is going to be a virtual conference or an actual conference. I'm so glad that you've come in out here. My brief today is to talk about the undefined atypical cystic tumor of the pancreas and a pragmatic decision making. I have no disclosures. See, the problem of an explosion of quality of diagnostic imaging has led us to diagnose cystic lesions of the pancreas. So I think it is important to have a fairly pragmatic, sort of a score sheet, if you will. The problem is that the pick rate of previously undetected asymptomatic cysts in a CT scan is 1.2 to 2.6%, in an MRI is 13.5, 19.9%, and an endoscopic EUS and an EUS FNA 95%, but differentiating between a benign and a malignant is still at a 40 to 93%. So what about the European guidelines? The biomarkers, CA19-9 in IPM is a grade 2C. Cis-fluid DNA markers for KRAS and for GNS, again a 2C. Radiological diagnosis of the type of PCN, MRI and MRCP 40 to 95% contribution, CECT sensitivity of 40 to 81%. On surveillance, MRI is a preferred grade, again a 2C, and a radiology, the role of CECT, particularly for calcification, vascular involvement, and recurrence. Following with the European guidelines, the role of EUS, adjunct to other radiological modalities, sensitivity for differentiating is 36 to 91%, and the role of the EUS FNA, where the diagnosis of MRI and CT is unclear, is 2C. Specificity is 83 to 100%, but sensitivity is only 27 to 48%. It's avoided when the distance is more than 10 centimeters, where the bleeding disorders, and if the patient is on antiplatelet therapy. So how do we go about it? Do you have an incidental pancreatic cyst? You will notice that serous cyst adenomas are largely asymptomatic. Mucinous cystic neoplasms are also relatively asymptomatic, but the moment you come into IPMNs, you have more of symptomatic, and ditto for ductal adenocarcinomas at 40 and 9% respectively. So what are the morphological clues? The morphological clues are based on the location, the status of the MPD, and the presence of absence of septae, loculations, and calcifications. So I'm going to take you through a bit. So following on that paper, the four major types can be identified, whether it's unilocular or oligolocular, pseudocyst, IPMN, serous cyst adenomas, mucinous, and SPNs, microcystic in serous cyst adenomas, macrocystic in MCN, SC, and IPMN, and cysts with a solid component are, IPMN, a mucinous cyst adenocarcinoma, and a solid pseudopapillary lesions. So you will notice that on the left side, there are patients who, the one on the far left is a young girl of 22 who presented with a uniform cyst. She actually had an SPN. The one down below is a 28-year-old, and she had an SPN, and I'll come to that a bit later. One on the right top is a pseudocyst, ditto for a pseudocyst at the head of the pancreas in the bottom picture. If you have a microcyst, you see on your left side that CT scan doesn't show us a centroid stellate scar. But on the right, when you do an endoscopic ultrasound, microcystic pattern is very evident. So that becomes far more obvious. If you have a macrocyst, it could be a mucinous cyst adenoma, serous, or an IPN, or an SPN. But if you have nodules and calcification, that points in the direction of an MCN. So these are some of the clues. If you have a cyst with a solid component, could be an IPN, MCN, SPN. This is a 28-year-old girl with an SPN. The pointer was that she was 28 years old, and I let you into another pointer, which is peculiar to our part of the country. And she had solid components out there. So, if we do a classification of pancreatic cysts by malignant potential, benign, pseudocysts, male more than female, unilocular with thick, or thin wall, pancreatic duct communication positive. You have an aspirate which is brownish, Ca low, amylase maybe high, inflammatory cells with debris, and you have a history of pancreatitis. In a serous, females more than males, mean age around 60. This is the traditionally known grandma cyst, microcystic honeycomb appearance in 80%. A central stellate car is not always present, sometimes in 20 to 30%. PD communication not present, Ca low, amylase low, serous glycogen rich, cuboidal cells which are alpha inhibin stains, and additional clues. If you are doing an FNA, you sometimes have a VHL mutation positive. A hydatid cyst is male, the same septated cyst, daughter cyst, spokes of wheel, patterns, calcifications. We thought that hydatid doesn't involve pancreas, but I'll show you my personal series, not series, case that we saw. Scoliosis may be present, membrane on an aspirate, may initiate an allergic reaction, so you need to be careful. And of course, you have a history and an IgG for echinococcus is positive. You see on the left side, far down below, a pure pseudocyst. You have a classic stellate scar in the middle picture, and that is obviously a serous cyst adenoma. And right up on the top, we had some issue about whether this was actually a serous cystic neoplasm, but it turned out to be a hydatid cyst. So you have to be a bit cautious. When we are taking you, I'm a dancer, so I'm taking you back to 1998, and where radiology wasn't very common, very prominent. So two of your organizing committee, myself and the organizing president, we were unfortunately doing this operation on different hospitals at the same day. The one on the left was mine. I was finishing that pseudocyst, and your organizing president, I see him sitting in the hall, Alok Banerjee, put in an incision and the blood hit the operating light. That was actually a pseudocyst. So that we published this paper in HBB. So what you need to be careful is if your pseudocyst isn't uniform, you need to have warning lights going on. So cysts with malignant potential, mucinous cyst adenocarcinoma, largely female, the mother cyst, well circumscribed, microcystic lesions, body and tail usually. It's clear viscous, Ca high, amylase variable, cuboidal and columnar mucinous cells, but you have a KRAS mutation, but the GNS is intact. Whereas in IPN, it's more or less equal between male and female. You have a dilated main pancreatic duct or branch duct. Sometimes you have a fish mouth papilla, and your endoscopists tell you that there's a discharge of mucus. It's clear viscous, Ca is usually high, amylase is high, and you have columnar papillary mucinous cells. There's a KRAS mutation and a GNS mutation in about 90%. So if you have a nodule or a calcification, warning signs, could this be a mucinous cyst adenoma rather than a pseudocyst? And of course, this is pictures from I downloaded this from the net because these show beautifully a main duct and a branch duct IPMN. So what about the malignant cyst? SPN, exclusively female daughter cyst, mixed solid and cystic component, but as I showed you in one of our pictures, one of our images, that we had a uniocular lesion, Ca low, amylase low, vimentin and alpha-1 antitryptans positive, beta-catenin stains positive, and 10% chance of metastases and diagnosis. If you have a mucinous cyst adenoma, female more than male, cystic lesions with mucin with solid components, viscous Ca high, Ca19 high, amylase low, KRAS mutation positive, PNET, male equal to female, solid with cystic necrosis, and Dr. Isabella showed you a number of pictures. Ca is low, amylase low, endocrine stains positive for synaptophysin and chromogranin, often with men's syndrome. Now, if you have a large lesion, you have something called a fluid layering. So this was our SPNs. You see one of the patients on your left with a single lesion, but the one on the right had intracystic solid components. Whereas in a mucinous cyst adenoma, you have nodules and you have lesions, irregular lesions inside the cyst. Now, this is interesting and has been contributed to by one of my colleagues. If you have a large PNET, it bleeds. Now, all tumors which are large bleeds, but you have something called a fluid interface. That's because the cells continue to elute protein-rich fluid. So you have something that is there, you have a fluid and a fluid layering. And if you have this in a large lesion or in a metastasis, you're almost certainly dealing with a PNET. So, intraduct papillary mucinous neoplasm, what are the guidelines? In the paucity of time, I'm going to, we had the Sendai AIP, International Association of Pancreatology, in 2006. In 212 at Fukuoka, worrisome features were, cyst size 3 centimeters or more, thickened or enhancing cyst wall, a main pancreatic duct 5 to 9 millimeter, a non-enhancing mural nodule, and an abrupt tapering of the pancreatic duct with distal duct atrophy. High-risk stigmata was this: obstructive jaundice, solid components, main pancreatic duct larger than 6 millimeter. The AGA in 2015 said that you have to have a presence of mural nodule, size more than 3 centimeters, ductal dilatation, and US shows malignancy. Now, if we go to the comparison, European IAP and AGA, they agreed on the main duct IPN, branch duct IPN, jaundice, enhancing nodule, and rapid growth and positive cytology you had to resect. But there were areas of disagreement. Now, what are the areas of disagreement? If you have a cyst size, the branch duct was more than 3 centimeters, IAP said go for resection. European, more than 3 centimeters if second feature present. AGA, more than 4 centimeters. Pancreatic duct size was 10 millimeter for IAP, less than more than 5 with the second feature present in European, more than 5 in AGA, and surveillance lifelong in an IAP, discontinue after 5 years of stability, and lifelong in an AGA. So which guidelines? You see, the difference between that was between sensitivity and specificity. So if you look at the data, we know sensitivity, what sensitivity and specificity is. If you compare different guidelines, specificity for IAP and European was 0. AGA had a higher specificity. So actually, if you think about it, the Europeans were more sensitive. IAP 206 moved down the line, IAP 2017, and AGA was very specific. So at the end, delegates, thank you for coming to Calcutta. That's a lifeline, that's a Hooghly liver, that's a beautiful picture. You have a combination of old and new, and thank you so much for.
Thank you, Dr. Sanjay. Very exhaustive talk with views about management and surveillance. What is your take on the surveillance for sub-centimeter pancreatic cysts?
Well, as I said, if you have a sub-centimeter, if you're worried about it, it might be worthwhile to follow them up on a more regular basis. Personally, I would do an endoscopic. We have an excellent medical gastroenterologist who actually follows these people up with regular endoscopic ultrasound. And we find that that actually avoids the pain of waiting 45 minutes for an MRI inside the gantry, or the additional radiology exposure in a CT scan. So we are in the process of switching over to endoscopic ultrasound surveillance.
Dr. Bakshi, do you recommend endoscopic ultrasound for all patients with cystic tumor of pancreas, or do you recommend it selectively?
We prefer doing that because we are in the process of evolution, and I think we are trying to set down some scoring system, so it's part of the trial actually, that we would expose them to endoscopic ultrasound even though your CT scan or an MRI might give you the diagnosis. So admittedly, if you have a mucinous adenoma, which is obvious, you have a nodule, I've shown some pictures, you would actually go up front, and there's no point doing an endoscopic ultrasound.
Imaging features are clearly suggestive. There may be some cases where imaging is clearly suggestive of a diagnosis. There are cases where it is not suggestive. So is there any difference, or your approach is same?
If it's clearly there, you go ahead and treat.
Yes.
If it's borderline, we're in the process of developing our own little trial. It's still in its infancy, so I can't give you data from it.
Thanks. I think there are no more questions. We can close again.
Thank
Thanks,
you.
Dr. Bakshi. And